because of the stomach. Can reduce the amount of intrinsic factor produced. Reduction, okay, in the amount of space available for vitamin B12. So the surface area, okay, of absorption of vitamin B12 is reduced because of gastrictum, part of the intestine, what we call gastrictum. A reduction in hydrochloric acid because once you remove a portion of your stomach, okay, sorry, not intestine, a part of your stomach, what happens is that you also reduce the amount of HCl that is going to be produced by the stomach mucosa. The rectal protein to release what? To release the B12, okay? Intestinal infections or conditions, this can interfere with absorption of vitamin B12. This one includes inflammatory bowel disease such as Crohn's disease and celiac disease. Tapeworms may have been ingested from eating contaminated fish have been noted to lead to lack of vitamin B12 because of interference in absorption. Other defects of DNA synthesis, such as congenital enzyme deficiency in DNA synthesis, resulting from therapy of drugs interfering with DNA synthesis, such as hydroxycobamine, azathioprine, midodrine, okay, and LZT, right? Those ones can actually lead to reduction, okay. Folate and vitamin B12 are necessary for the synthesis of DNA because this is what we have seen. Therefore, when you have lack of folate and vitamin B12, this one leads to impairment in the synthesis of DNA precursors, which in turn cause megaloblastic anemia, hyperpigmented neutrophil, megaloblastic changes, and rapidly dividing epithelial cells, that is the intestines. Okay. Let's look at folate deficiency. This one is obtained from green leafy vegetables such as spinach, broccoli. So what you're talking about, green leafy vegetables, okay, and also liver and kidney, also in some fruits. And this one is usually absorbed in the jejunum. Now, folate usually deficiency develops within months because of the body stores are minimal. Okay? Now, when you're saying that the body stores are minimal, you say, and you're going to see the next slide, is that usually about 3 months, okay, storage of folate. And therefore, you're more likely to get folate deficiency than vitamin B12 deficiency. Then again, cooking causes a loss of about 60 to 90% of the folate. Right? So when you're cooking, you're not supposed to overcook your vegetables, so that now you end up losing your weight. The minimum requirement is about 100 micrograms per day. Can also lead to other causes of folate deficiency. Can be due to poor intake. Poor intake can be right in alcoholics. Okay, alcoholics very, very important. Alcohol is very important. Like alcohol reduces absorption of vitamin B12. Anorexia, diseases such as partial gastrectomy that we have seen, IBS, inflammatory bowel syndrome or diseases such as celiac and Crohn's disease can also lead to folate deficiency. The reason is because folic acid is actually absorbed within the large intestine. Say that the normal body stores is about 3 months. Deficiency is very common. Unlike vitamin B12, vitamin B12 is stored in the liver up to 12 months, and therefore, when you see somebody having vitamin B12 deficiency, in that there is actually a very big deal. That's we say that the deficiency has been developing for a prolonged period of time. Now we have antifolate drugs, and One of the most important one is phenytoin. Phenytoin is an anti-epileptic, okay, anti-epileptic phenytoin. Now this one usually prevents absorption, the precursors of uh, folate being absorbed and causes it to uh, get diminished. Therefore, what happens, especially for people who are epileptic, you find that this is one of the drugs that, of course, usually causes folic acid deficiency. And therefore, when you're giving anti-epileptics such as phenytoin, what you're supposed to do is that you're supposed to give a daily maintenance dose or a prophylaxis uh, with folic acid, which is usually about 5 milligrams once per day, or you can give actually what we call a pulse treatment. Now, I repeat again, when you're giving pulse treatment, you say that, you say you can give, let's say, for example, you give like, let's say, for 3 months, then you stop for 1 month, continue for 3 months, then you stop for 1 month, okay? When these patients are on phenytoin. Now, for female patients who don't have any other alternative of using anti-epileptic drugs, all right, if they are on phenytoin, they are supposed to be on prophylactic of folic acid. This is to prevent neurotube defects, especially if they were to get pregnant accidentally. But we always advise that for patients who want to get pregnant and they're epileptic and they are taking phenytoin, then they should be switched on to a different anti-epileptic to prevent those serious neurotube defects. Okay. Methotrexate, this is an immunosuppressant, and we have trimethoprim. This is septrin. Okay. All these can cause a reduction in deficiency for the pregnancy in lactation due to increased demand. Okay. Hemolysis and also some cancers can also lead to folic acid deficiency. Say that alcohol decreases vitamin B12 absorption. You can also have liver diseases, okay? Right? So liver diseases here, we're talking about when you have liver disease, you end up having poor diet and absorption, and right? And hypothyroidism, okay? Now, in a patient with hypothyroidism, what happens is that you end up having a thyroid hormone which stimulates the production of erythropoietin, okay? So especially this one is very, very important, okay? Some hematological conditions or disorders such as aplastic anemia, sideroblastic, all this, okay? If it result in sideroblastic anemia, okay, due to impaired DNA. This one you have seen it, okay? So let me just move on to the next, right? Next slide. Here we are talking about signs and symptoms of macrocytic anemia. Okay, so macrocytic is also called megaloblastic anemia, large cells. Okay, MCV of more than 100. So a patient may end up experiencing or presenting with neurological symptoms. Okay, due to damage of the myelin sheath. Okay, what we call subacute combined degeneration of the cord. Right. So the classic symptoms that will be seen, especially in vitamin B12 deficiency, and here we are talking about severe vitamin B12 deficiency, is a patient will develop, of course, those peripheral nervous system manifestations such as central and peripheral nervous system manifestations such as paresthesia of the fingers of the toe, loss of vibration sense, okay, and proprioception, okay, right? So when you're talking about loss of vibration sense, okay, when you're in your central nervous system examination, okay, in your central nervous system examination, we talk about sensory system, okay? So sensory system, what we are looking here, we are looking at the vibration sense, okay? So you hit the tuning fork and then you place that tuning fork on a prominent part of your body, of the patient's body, sorry. So if the patient is not able to perceive loss, vibration, then you term that patient as loss of vibration sense. In proprioception, all right? In proprioception, what happens is that because of loss of these or damage to the myelin sheath, okay, what happens is that uh, the senses that are usually able to perceive the sense of direction, okay, what we call direction. Direction is also what we call proprioception, is also loss because of loss of this myelin sheath that usually are able to are supposed actually to propel, okay, the senses from below the feet up to the brain, okay. Now, what happens is that in proprioception, what happens is that you tell the patient, you grab the patient's toe and you try to flex and extend, okay. So it's called position sense, not direction. It's called position sense, okay. So when you flex and extend the patient's toe, the patient may not be able to feel if you are flexing or extending that toe. And therefore, the patient has loss of proprioception, okay. Then there's progressive weakness and ataxia, because majorly because of damage of the myelin sheath, okay. You know, the myelin sheath is very important, especially in propagating, okay, in propagating the senses from one myelin sheath to the other, okay. Paraplegia may ensue, right? So paraplegia may ensue. There is what you call the positive Babinski reflex. A patient may present with dementia and may end up having what you call elevated malonic acid and serum homocysteine. Okay, serum homocysteine and serum methylmalonic acid. Okay, right. So serum if when you're talking about homocysteine, yeah. Now homocysteine is an amino acid, okay, which is very very important. Okay, um, especially when you are breaking down. Okay, so vitamin B12 and folate usually break down homocysteine. Okay, to create other precursors for the body needs. Okay, and therefore this one is very very important. And therefore, when you have high homocysteine levels, this means that you have vitamin B12 and vitamin B12 and also folate deficiency. Right. Of course, as we have said that these ones have direct neurotoxic effects when they are elevated. Okay. Now, psychiatric symptoms may also ensue, especially in patients with megaloblastic anemia. This one is because vitamin B12 is important, is producing what we call brain chemicals that affect mood and other functions. Therefore, one of the investigations that you're supposed to do when you see a psychiatric patient is to do a serum vitamin B12 levels. A patient may present with depression, apathy, irritability, dementia, catatonia, delirium, and hallucination. Of course, at the worst time, depression and psychosis are, of course, one of the highest, uh, one of the, of course, extreme symptoms. We say that vitamin B12 deficiency may be a risk factor for schizophrenia. So, serum vitamin B12 for patients who are presenting with psychiatric symptoms should always be included in your investigation. Signs and other signs and symptoms include decreased appetite, irritability, lack of energy. Of course, this one is anemia. Um, difficulty in walking, numbness, tingling. This one you talked about. That is peripheral neuropathy. So patient will present with peripheral neuropathy, smooth and tender tongue, that is glossitis. Okay, like the way we are seeing. Okay. So fissured tongue, and of course it's phlegm, that is what we call glossitis. The patient will present with what we call the subacute combined degeneration of the cord, especially in the extreme situation, okay, whereby there is degeneration of the dorsal columns and the lateral column of the spinal cord due to demyelination. And we say that demyelination is because of lack of vitamin B12. Right. Looked at the signs and symptoms of vitamin B12 deficiency, which, of course, when a patient presents with subacute combined degeneration of the cord, all right, the patient will present with sensory deficit, paresthesia, weakness, ataxia, gait disturbance. Okay. Of course, in severe cases, it can lead to spasticity and also paraplegia, mainly because of degeneration of the dorsal column. Okay. How do we investigate a patient who comes with megaloblastic anemia? One, you do your full hemogram. Okay. You do your full hemogram. So in your full hemogram, you have increased MCV and MCH. Sometimes you end up having normal MCH. But as you say, sometimes you can have false or normal MCV in megaloblastic anemia. So keep that in mind. The RBCs will be low because you need folic acid and also vitamin B12, especially in DNA synthesis. Therefore, you end up having reduced red blood cells. If you don't have reduced, you have what you call reticulocytes, especially in your peripheral blood film. Okay, sorry, in the blood, you have reticulocyte count increased. Okay, HB level will be reduced, WBC will be reduced, and platelet counts will be reduced. Okay, when you do what you call a peripheral blood film, so number two, you do your reticulocyte count. You have low reticulocyte count. Number three, the reason why you have low reticulocyte count is because one is that you need vitamin B12 for the synthesis. Okay. Now you have immature red blood cells that are coming out into the circulation. Peripheral blood film is your third investigation. The peripheral blood film will show macrocytic ovalocytes. These are oval cells and teardrops. So when you're seeing macrocytic ovalocytes, you're seeing and the ovalocytes, teardrop cells. Now you've started seeing abnormal cells in the peripheral blood film. You may end up seeing anisocytosis. This is unequal in color. You may end up seeing what you call poikilocytosis, abnormal shape. This is your peripheral blood film report. Okay, right? Schizocytes due to breakage, hyperplasia due to low myeloid to erythroid ratio. Okay, now in severe cases, all right, you may end up having leukopenia. Leukopenia is reduction in WBC count, okay, and thrombocytopenia. Thrombocytopenia is whereby you have reduction in the platelets, okay. You do your serum folate and serum vitamin B12, okay, right? can also do your serum homocysteine. We say that homocysteine is an amino acid that is very important, especially in ensuring the precursors of other precursors are taken care or are usually taken care of vitamin B12 and folate. And therefore, what happens is that when you have reduction, okay, when you have vitamin B12 and folate, you have serum level of homocysteine which is increased, including methylmalonic acid or MMA. Okay, shilling test nowadays is not currently used, especially in investigation, because you have these other tests that have come up. Talked about peripheral blood film, talked about a bone marrow aspirate. Now, when you see an abnormal blood cell, especially in the periphery, okay, or in the peripheral blood film, so what you go to the bone marrow, try to find out exactly what is happening. So these are patients when you see, okay, when you see in your peripheral blood film, yeah, this one, when you see that in your peripheral blood film, you have this kind of picture, okay. A peripheral blood film is also known as blood picture. When you see this kind of a picture where you have anisocytosis, oikocytosis, schizocytes, or microcytes, next thing that you need to do is that you need to do your bone marrow aspirate or BMA, okay, to try to find out the source of where you have abnormal cells coming. Okay, other tests, antiparietal cells, anti-intrinsic, antibodies. Those ones can be done in major facilities that have, right? Of course, your history is very important. History of gastritis, history of ileal resection. Okay, very, very important. Then, of course, the megaloblastic anemia. You look at the red blood cells and you can see they are big, shape, size. Okay, big in shape and size, as you can see. Okay. Then you have hypersegmented neutrophils. We say that hypersegmented neutrophils have 6 or more lobes. Okay. Yeah. So we talked about serum methylmalonic acid. Okay, so this one, the MMA. Okay, apart from homocysteine, MMA is a substance that is created when your body digests what you call some certain types of proteins. Okay, therefore, what happens is that the amount of vitamin B12 in your body controls how much MMA your body makes. So high methylmalonic acid typically means that you have vitamin B12 deficiency. Okay. Treatment of vitamin B12 deficiency. If it is severe, admit the patient. Okay. The patient might be presenting, of course, with looking at your history. Okay. Fatigue, glossitis, patient presenting with those peripheral nervous deficiency symptoms such as peripheral neuropathy, vibration sense deficits. Patient will present with other symptoms that are typical of vitamin B12 deficiency. Admit that patient. The patient present with psychiatric symptoms due to vitamin B12. As you take your history, admit that patient. And so you can treat with intramuscular injection. It's cobalamin, cyanide, no, cobalamin. Okay. Now, the guidelines from the British Society for Hematology. Now, what this says, okay, says that it might be different from what we are practicing here, but what the British Society for Hematology recommends is that you have injections about 3 times per week for 2 weeks. Okay, in patients without neurological deficit. If a patient has neurological deficits, what you should do, you should be given every other day Every other day means that you give an alternate days for up to 3 weeks or until no further improvement is noted. So it's like you're going to inject this patient until you give up. Right? So we say that inpatient treatment, observe the patient. Hypokalemia may ensue due to rapid development of RBC. Now, what happens is that, as you know very well, that now if you rupture the red blood cells, okay, if you rupture the red blood cells, what happens is that you end up releasing potassium into the circulation. Now, this one is the opposite of what happens when you have increased development of red blood cells. So, in this case, what happens is that more of these potassium will actually escape into the red blood cells, okay, causing reduction in potassium, and this one may lead to death. And therefore, what you need to do is that you need to do your serial potassium levels as you observe these patients. Now, patients with irreversible causes should be treated indefinitely. I don't know if that one can happen in Kenya, all right? But those ones with reversible cause should be treated until the deficiency is corrected, okay? So we've looked at causes of vitamin B12, okay? So if vitamin B12 deficiency coincides with folate deficiency, what you need to do is that, right? Replace first vitamin B12, okay, to avoid what? Subacute combined degeneration of the cord, right? So British Society for Hematology does not recommend retesting vitamin B12 after treatment has been initiated, okay? There's no guidelines for that. So we said mild to moderate 1,000 micrograms of vitamin B12. Here we are talking about treatment with vitamin B12, okay? IM, okay, for 2 weeks situation. Then twice weekly, as long as improvement is occurring. Maintenance dose 1,000 micrograms every 1 to 3 months as required for the rest of the patient's life. This patient will be getting 1,000 micrograms of vitamin for the patient for the rest of his life. And also supplement with oral vitamin B12. In most cases, vitamin B12 is better to be given with IM injection. Reason is because one is that you don't have any problem as far as absorption of vitamin B12 is concerned. That one goes straight into the patient's system. When you give oral medication, of course, you have these problems of absorption of vitamin B12, gastrectomy, alcoholism, nausea, and vomiting. All those, okay? Say that nerve damage from vitamin B12 deficiency is usually permanent, okay? All right, so this one cannot be salvaged. And you should be able to see the normal HB and hematocrit within 2 to 3 months. So we said 100 to 1,000 micrograms vitamin B12 daily or weekly, or every other day for 1 to 2 weeks. Maintenance is about 100 to 1,000 micrograms. I am once a month for life. Okay. Folic acid, right, is also the treatment. Why is it that you give folic acid with vitamin B12? You should never treat only vitamin B12 alone or folic acid alone, right? Right. So it's what we call the tetrahydrofolate pool, okay? Right, that usually corrects the anemia, all right? So the neurological symptoms are usually not corrected by folic acid. Therefore, that is why you're supposed to give it with vitamin B, vitamin B12, okay? We have looked at sources of vitamin B12, right? Talked about dietary deficiencies, that one you've looked at, okay? All right, so we say that maternal folic acid deficiency might lead to neurotube defects, especially in the fetus. So folic acid supplementation is recommended prior and during pregnancy, right? Pregnant women. say that you're going to look at anemia in pregnancy. So I'm sure you'll touch on something to do with folic acid and the importance of taking folic acid in pregnancy. Say that folic acid supplements will correct the anemia, but not the urological deficit of cobalamin deficiency. Okay, so the daily dosage is 5 milligrams once per day for 3 to 6 months. Prevention of megaloblastic anemia. So what you need to do is that you need to screen patients for vitamin B12. History is also very important. Right? Say that patients who are taking proton pump inhibitors or H2 receptor antagonists, which I didn't put in my notes. All right. Now, what happens is that if a patient takes the PPIs, okay, or the PPIs usually reduces the acid, okay, and the hydrochloric acid is very, very important, especially in breaking down the protein, right, that carries the vitamin B12. Therefore, when you take antacids, not antacid, when you take PPIs and H2 receptor antagonists, you are severely decreasing the HCl content into the stomach. Subsequently, you're going to reduce the amount of folic acid that you're going to absorb. Okay? If you had bariatric surgery is usually done to reduce the length of your stomach, your intestine, sorry, not stomach, the length of your intestine, so that you should be able, now you can be able to eat less, okay? And we say that gastrectomy reduces the amount of your stomach, I mean the surface area of your stomach, the length of your stomach, the length of your intestine, okay? So what happens is that in bariatric surgery, if you know very well that vitamin B12 and also, again, some form of, vitamin B12 and folic acid is partially absorbed in the large intestine, small intestine, and also some in the large intestine. So what happens is that when you have this bariatric surgery, what happens is that you end up reducing the surface area for absorption of both vitamin B12 and folic acid. Therefore, what you need is that you need to take a supplement every day, 1 milligram oral vitamin B12 indefinitely. Any question? So that is vitamin B12 deficiency. And if there are no questions, then we can stop. Continue. Anemia is a very long, long topic. Okay, but you cannot finish. You have hemolytic anemia, anemia due to chronic disease. So those ones we are going to cover in our next presentation. So thank you. We shall continue next week.